everyone, thank you for tuning in. Joining me today is Professor Faisal Ali, who is a multi-award winning consultant dermatologist, and he has a special interest in disorders of pigmentation. And that is the subject of our discussion today. Faisal is more usually in the mainstream media, but he has kindly agreed to come onto the show, for which I am extremely grateful. Faisal, welcome. Thank you so much for joining me today.
Oh, it's a real pleasure to be invited. Thank you very much for the invitation.
And Faisal, as you know, this podcast is aimed at educating patients. So we try to, if at all possible, avoid complex medical terminology or jargon so that it remains as accessible as possible to everyone.
Oh, of course, yeah.
So let's get into it. Can you explain what the term disorders of pigmentation refer to?
Well, I suppose if we start off with the term pigmentation, that refers to the colour of whether it's your skin, your hair, your eyes, or even your nails. And it's governed by the amount of a substance called melanin in your skin. And if you have more melanin, your skin or your hair appears to be more pigmented or slightly more coloured or darker. And if there's less melanin in the skin, it appears to be slightly lighter or less pigmented. So, disorders of pigmentation refer to either an increase or decrease in the amount of melanin in your skin, so that one area of your skin may appear darker or lighter than the surrounding skin. And there are lots of different reasons for this. I mean, sometimes it's related to sunlight exposure. Part of it is related to the aging process, so a phenomenon called photoaging, which is aging which is induced by the sun over many, many years. Sometimes it can be associated with an inflammatory disorder or inflammation of the skin or an autoimmune disorder. Sometimes it's related to underlying hormones, and sometimes it's related to underlying medical conditions or drugs that you may be given.
Okay. And are there any sort of broad categories? Because it sounds like it sounds like there are many of them.
Yeah, of
Are there
course.
any like broad categories you can break them down into for us?
I mean, broadly speaking, I would categorize them as terms of hyperpigmentation, so
Yeah.
increased pigmentation in the skin, and hypopigmentation or decreased pigmentation of the skin. And when we look at hyperpigmentation, actually, there was a very helpful study produced by one of the big companies, L'Oreal, a few years ago, which showed that actually 50% of the world's population, on average, are affected by a pigmentary disorder at any point in time. So they did a worldwide study, I think it was about 50,000 patients, and 50% of those people that they interviewed were affected by some sort of pigmentary condition. And when you looked at the sort of top 5 or 6 conditions, it was very, very similar country to country, wherever you were in the world. Certain ones were number one in some country and number 5 in the other, but the top 5 or 6 were relatively similar. So often what was number one was photoaging or pigmentation relating to aging caused by sunlight. And that could also include a condition called melasma, which I think we're probably going to speak a little bit more about as we go on.
Okay.
Pigmentation, so around the eye, so periorbital pigmentation and pigmentation of the armpits also bothered a lot of people. Also, post-inflammatory hyperpigmentation. So what that is an increase of pigmentation caused by another skin condition. So, for example, if you have acne or eczema or psoriasis, and that's left untreated, particularly in people with coloured skin or pigmented skin, it can leave dark spots there afterwards, and that also is a great concern to patients as well. And on the other side of the spectrum, when we look at hypopigmentation or loss of pigment, the common one that obviously people think about is a condition called vitiligo, in which your body's immune system attacks its own cells. And now, many of these conditions, they're not necessarily life-threatening, but they're certainly life-impacting. So when I meet patients with pigmentary disorders, both hyperpigmentation and hypopigmentation, they often report that it's impacting on their relationships with their family, their friends, their colleagues at work. They might not want to form new relationships. They might not apply for a job or want to go for an interview. They feel that often people perceive them as being dirty or not looking after their own appearance. They think that they're treated differently by friends and family. they often say that people might not be sitting next to them on a bus or a train, and they perceive that they're discriminated against at work. And many of them report feeling less loved by their friends or family. They sometimes feel they brought shame on their family. In certain cultures, they might not want to get married because of their disordered pigmentation. So, whilst these conditions often aren't life threatening or life shortening,
Okay.
they hugely impact on people's lives. And there are lots of treatments for them out there now.
Right, okay. Well, that's good to know, because everything you've listed so far sounds like it's really, really common. And what areas of the body are more impacted? Is there a difference in the distribution on the body? Is it the sun exposed areas, hence, face, for example, so visible on the bus, etc., as you say, or is it kind of throughout the body? How does it distribute itself?
I mean, potentially any area of the body could be affected by a disordered pigmentation, but if it's on one of those parts of the body which people are seeing on a day to day basis, it's probably more impactful for the
Yeah.
patient. What I mean by that is that if you've got darkening or lightening of the skin on your face, or maybe even the backs of your hands, people are seeing that on a day to day basis, and you may feel that people are judging you or guessing what it might be, wondering if it might be contagious, which almost certainly it's not. So it's often the parts which are most visible, the face, the head and neck, the backs of the hands, where it's most impactful. Certain conditions do have certain predispositions for certain parts of the body. So, for example, the condition melasma tends to affect people on parts of the body which are exposed to the sun. So, typically the face, the
Hmm.
central forehead, the middle of your cheek. But other conditions, like on the other end of the spectrum, vitiligo, that can affect any part of the body. So, it may be on the face or on the backs of the hands where people can see it, but it can be anywhere over the body, including the genitals, including the armpits, and actually including the hair follicles as well. So with vitiligo, where you lose your pigment, sometimes people can have a patch of hair on their eyebrow or in their scalp where they'll just have a patch of white hair there. And that, again, it can be hugely impactful for that particular patient.
Okay. And are there any risk factors for developing pigmentation?
So
Is
again,
there anything that patients can do to avoid it, for example?
Again, it depends on what the underlying cause for that pigmentation is. So there are many causes. I suppose the one
Yeah.
that everybody is, I think, of all different skin colors are becoming more aware of is the impact of the sun on um, age-related and sun-related pigmentation on photoaging. So if you wanted to avoid sunspots, which can occur as you get older, using a broad spectrum sunblock, potentially every day of the year, but certainly in the summer months, can help,
Yeah.
if not entirely prevent, reduce the number of these age-related sunspots that you get over time. So using a sunblock regularly can sometimes help. I think also in some women in particular, using estrogen containing either contraceptives or the hormone replacement therapy can promote pigmentation as well. So if you are somebody that's developing a pigmentary condition such as melasma or chloasma, and it's thought to be related possibly to your contraceptive pill, it may be worth asking if you're able to switch, or your GP might wonder if it's worth switching from an estrogen containing contraceptive pill to one that either doesn't contain estrogen, like a progesterone
Yeah.
containing pill, or something that doesn't contain any hormones at all,
Right. Like the non-hormonal coil, for example.
such as the non hormonal coil. Yeah.
Yeah. Okay. That's right up my street.
Yeah,
Some
I
gynecology.
thought so. I thought I'd defer to that. I'd defer to your greater knowledge on that.
Thank you. Thank you. Okay. And is that so? So you mentioned that pigmentation can be a kind of longer term outcome of acne or other skin conditions. Are
Mm.
there any kind of generalized medical conditions that can produce pigmentation? Or, for example, if someone saw pigmentation, should they worry that maybe it's a sign of an underlying illness?
I think that in terms of what's most common, I think in terms of pigmentation being related to an underlying condition, it would be an underlying skin-related condition, and that may be something your body produces itself. So something like acne, something like eczema, something like psoriasis in
Okay.
anybody, but particularly if you've got darker skin, when you have an inflammatory skin condition, when it heals, it can leave a darker patch there afterwards. So if you do have an inflammatory skin condition, acne, eczema, psoriasis, and you think you're developing features of pigmentation, I would see whether it's your primary care physician, your GP, your dermatologist sooner rather than later, because the best way of
Yeah.
stopping that sort of pigmentary condition is to treat the underlying skin issue first. And as well as that, sometimes people get post inflammatory hyperpigmentation caused by things that we do to ourselves. So, like laser treatments and peels. So, people might have gone for a chemical peel and it's left pigmentation there, or laser treatments and it's left pigmentation. My advice to those people would be number one is stop getting the laser treatments or peels, so you're not inducing more pigmentation. But also, again, see your medical practitioner sooner rather than later to see if there are treatments that you can use sooner rather than later. There are other medical conditions that can be associated with pigmentary disorders. So sometimes you can get acanthosis nigricans, which is like a velvety appearance on the skin, and that can be associated with underlying diabetes. You can get other problems with your hormone system, the endocrine system, a condition called Addison's disease, which can sometimes cause
Yeah.
pigmented patches on the body as well. Um, and as well as that, there's a whole category which I haven't really touched on is discrete spots of pigmentation or patches of pigmentation. If it's one spot rather than all over the body or all over the face, whether if it's a new one in particular, think about whether it could be cancerous. So if it's something that's new, if it's growing, if it's painful, if there are two or more colors within it, again, have it checked out sooner rather than later, particularly if it looks different to any of the other spots that you might have on your body.
Okay. So if someone developed, say, several spots
Mm-hmm.
of pigmentation, and they were concerned about it, your advice, it sounds to me, would be address it as soon as possible. Don't wait and wait and wait till you get more and more and more. Is that because treatment works better the earlier it is instituted, and results are better?
Absolutely. So the best means of treating pigmentation is to avoid it. And that's the same as with many medical conditions, not just skin conditions, but I find particularly with pigmentary conditions. So if you've got the beginnings of dark patches on your skin or dark spots, which may be related to underlying eczema or acne, have your eczema
Hmm.
or acne or whatever else it might be treated sooner rather than later. And it might be that your doctor has more effective treatments available to them than you can buy over the counter. With eczema, another problem sometimes people have is that they're developing dark patches near the eyes or on the face, and it might be related to an allergy to something, to a hair dye allergy, for example, or to a acrylic nail allergy. And it might be that as well as treatment for their eczema or psoriasis, they might need referral for allergy testing to make sure they're not
Wow.
allergic to something. With regard to uh, hypopigmentation, so vitiligo.
Yeah.
Historically, certainly in the UK, vitiligo has not really been actively treated. People were told that there's not really any treatments for vitiligo, and that myth has sort of perpetuated over time. What I would say, if there's anybody with vitiligo or with hypopigmentation, loss of pigment on the skin, particularly if it's within the first 6 to 12 months of it appearing, there are newer treatments out there. There are topical creams, so steroid creams, tacrolimus cream that can be given by your GP, your primary care physician, or your dermatologist. There's phototherapy, which is a light treatment which can help stop the spread of pigmentation and encourage some of the pigmentation to come back. There are also tablet treatments now as well, and newer biologic treatments again, which can enhance how quickly the pigment can come back as well. So, but the sooner
Wow.
you are seen, the better chance you have of recovering your normal skin color as soon as possible.
Okay, that's really fascinating. So I think that there are certain barriers to accessing medical care,
Mm.
for patients, and one is not being sure of what will happen when they seek care. You know, what investigations will be needed. Will it be
Mm,
painful? You know, that, you know, there's this whole not knowing what to expect,
mm.
which I'm sure you can clarify for us. And the other reason is exactly what you've mentioned there is, well, I don't think there is anything that can help me. You know, so why bother? So thank you for mentioning that there are so many effective treatments that have been developed, because medical research and developments just go on and on. And even though there may not have been a treatment for something 10, 20 years ago, that it may be quite a different situation today.
Mm.
So getting back to the barrier of what to expect, if I noticed some pigmentation on my face, for example, and maybe it wasn't going away, and I thought, yeah, I'll check this out and go along to my GP. Can you tell me what my journey is likely to be like? What should I expect?
Yeah, absolutely, and that's a really good point that you raised. So when you see your GP with a with any sort of medical condition, but with particularly with a condition of pigmentation, I think first of all they would start off by having a chat with you. They would take a full
Hmm.
medical history to ask about how long that patch of pigmentation has been there, what treatments you may have tried yourself over the counter, when you noticed it, if it's itchy, if you've got other patches on your body that you've not yet told them about. They may well ask about other medications you're on, because sometimes some medications can be associated with pigmentation as well. And they may ask about whether other members of your family have been affected by similar medical problems previously. Because certain conditions, for example, vitiligo, just because you have it doesn't mean to say your children will have it, but there is a slightly higher risk that if a parent has it, a slightly higher risk than that their child will have it compared to the general population. So first of all would be a medical history being taken. The next thing would be they would be examined properly. Now, first of all, that would be with the naked eye. So your GP or dermatologist would look at you with their naked eye to begin with. Many GP practices, and certainly most dermatologists, would have a magnifying glass called a dermatoscope. So it's a very fancy magnifying glass that has different wavelengths of light within there. So they would have a look with that. And in some practices, so if you were to see me or many dermatologists, we'd have something called a wood lamp, which is an ultraviolet lamp. You'll often see it being used to detect counterfeit money. So you'll shine your banknotes under it to make sure it's genuine money. And I think they also use them to look at pet urine as well. But in this case, actually, it's very, very useful for looking at pigmentation to see exactly where it is in the skin. So that would be done as well. All of those are non-invasive. They're non-invasive, no needles involved, and hopefully within a few minutes of examining you, they'd be able to have a rough idea as to what was going on. It may well be, as well as examining if, for example, you went with pigmentation on the face, they may ask to look elsewhere on the body, because sometimes you can get clues elsewhere on the body as to what the underlying cause for the pigmentation is, and then how best you can treat that. Um, the other thing then, if they're not sure what, if somebody comes to me, they've got a patch of pigmentation, or indeed any other skin disease, and you're not sure what it might be, you might be referred for what's called a skin biopsy. Now, skin biopsies are all done under local anaesthetic, so you're awake the entire time. And normally, the way dermatologists do them, so skin specialists like me, we would inject a local anaesthetic into the area of skin that we're taking the biopsy from. So that feels a little bit like a bee sting. Within 2 to 3 minutes, that should have had its effect. So after that, all you should feel is pushing and pulling. You shouldn't feel anything sharp after that point. They would normally then take a 4 millimeter punch biopsy, which is like a hole punch. That would just be inserted into the skin. That little circle of skin will be taken out. And then the hole that's left there in the skin will be sewed together with a couple of stitches, which would be removed normally after about 7 to 10 days. What would then happen to the actual sample itself is that would then be sent off to a lab, and it's then processed. It sometimes is embedded and has certain stains applied, and then looked at under a microscope by a specialized pathologist. So that's normally a doctor that is trained at looking at slides. So they're trained at looking at pieces of tissue, whether it's the skin or other parts of the body, and they look at that under a microscope to see if there are certain patterns there that indicate what this condition might be. That report then will go back to the doctor that requested the biopsy, and they'll look at that report, they'll tie it together with what they thought from when they examined you, and then they'd hopefully then be able to give you a diagnosis and a management plan. Now, sometimes people also, if it's a rarer condition, something like, for example, lupus, which is causing post-inflammatory hyperpigmentation, it might be that the doctor requests a series of blood tests as well. Again, that would involve a needle in the arm. It takes about 30 seconds, maybe a minute to do, and the blood samples are sent off to a local lab, and certain parameters are looked at to see if they can give a clue as to what the underlying diagnosis is and whether further treatment is needed as well. And that, I think, with the other investigation that is sometimes performed is patch testing, which I alluded to before. So if your doctor suspects that you might be allergic to something coming into contact with the skin, and the typical ones that I see in my clinical practice, the number one, I think, would be hair dye. And that can be dark hair dye, it can be blonde hair dye, and it can even be the one that has been used for many, many years. So the story I normally get is, I've been using the same hair dye for 20 years. It can't be that one. But the way in which contact allergies form, unfortunately, is you need to be sensitized to something that you've used previously. So that's commonly the story we get, is that it's the same hair dye or product someone's used for 15, 20 years, and they, for whatever reason, developed an allergy to it. And that, again, can induce eczema and induce post-inflammatory hyperpigmentation. As well as hair dye, the other common culprit that I'm increasingly seeing are nails as well, so acrylic nails and gel nails. So again, that might be another sort of investigation you'd need doing. With patch testing for allergies, what that involves is you'd be referred to a patch test centre or an allergy centre. They would put on about 50 to 100 stickers on your back, and they would be left there for 5 days. So you'd go in on a Monday, you'd have these 50 to 100 stickers put on your back. Each of them has a specific allergen on them. You'd come back on the Wednesday, they'd peel those off, and then you'd come back again on the Friday when they would do a final reading. And you're not allowed to wash between the Monday and the Friday. So the inconvenience of it is normally the part that patients don't like. But it can give you very, very helpful answers to say that this person is either allergic to something, and by avoiding that, it might be able to stop their skin disease, or they're not allergic to anything that we can detect, so we can push ahead with their current treatments and they're fine to use the products they're already using.
So something's occurred to me while you were talking. So would you say the majority of patients you see with this problem are female? Or is that not necessarily the case?
I think that is true. I think it depends on the condition. And I think it's a problem. I think there's two issues here. It's two questions, I should say. Number one, are the conditions more common in females than males? And I think the second aspect is, even if they're equally common in both sexes, are both sexes just as likely to go to their doctor with it? So I think certain conditions...
Both the hair dye and the...
Yeah, so absolutely. So certain conditions, I think we do know are more common in females than males. So I think melasma is one, and that's when you get these dark patches appearing typically on the face, typically in women, and it's often associated with some underlying hormonal treatment as well. It can occur, remember, it's far more common in women and seems to be far more debilitating for women. Far more life impacting for women than it is for men. Something like photoaging, so where you develop dark spots on the face which are caused by the sun. I don't have the statistics in my mind, but I am, as well as a dermatologist, I'm a Mohs surgeon and laser surgeon as well, so I deal with a lot of skin cancers. But what you see is these solar lentigines, these patches of sun damage, are more common in patients who have skin cancer. And I think photoaging is probably similar in both men and women, but women are probably more bothered about it at a lower threshold than men might be. So we probably see disproportionately high numbers of women with photoaging at an earlier stage because they present at an earlier stage. And then there are other conditions like vitiligo as well. And so vitiligo, where you lose your pigment and it's caused by an autoimmune condition. Again, with that, men will probably present later than women would. So by the time men present, they'll probably present with more extensive disease than women would as well. So I'd say to anybody watching or listening that if you are looking after, if you've got other men as partners or in your family and they do have skin problems, encourage them to see a doctor sooner rather than later. I think something else I would touch on as well is that with certain conditions, so there is a discrepancy when you look at patients who have skin of color compared to what we refer to now as white skin. So patients with darker skin, for a variety of reasons, certainly in the US and I think probably in the UK as well, present later to their dermatologist with and when they do present to their dermatologist with any skin disease, it seems to be at a later stage, a more advanced stage, and sometimes slightly trickier to control. And that is for a whole host of reasons. I think there are some cultural reasons why that might be the case. I think there is an element of historically, a lot of dermatologists were taught on Eurocentric skin type. So we were predominantly taught using skin diseases in white patients as opposed to patients with coloured skin. And again, partly that might be because they're easy to photograph, partly because until relatively recently, thought wasn't really given to it. And that was reflected in not just the medical school curricula, but also if you look at historical, and by historical, I'm talking 10, 15 years ago, not last century. I'm talking relatively recently.
Oh, right, okay.
Relatively recently, the number of people with skin of color was not represented in dermatology textbooks. So if you look around the world, about over half the world have skin of color to some degree. Whereas that isn't represented, or certainly wasn't represented in previous dermatology textbooks. So it means that the dermatologists, the primary care physicians, the GPs are less confident at diagnosing certain skin diseases in certain ethnic groups and patients with skin of color, which means that their disease might be recognized later, and then it takes them longer to be referred to a dermatologist or the appropriate body for further treatment. So again, I would say that there is that discrepancy that also exists as well. So if you have, for every patient, but for those with skin of color, if you feel that you've still got itching, that you might have, your skin might be slightly brown rather than slightly red, still by all means see your GP, because there will be other treatments that can be offered for you.
Okay, and another thought entered my mind. I have so many questions. So vitiligo, for example, is that always progressive, or do people not go along because they think, well, I can deal with this one patch or this small area of skin that I've lost pigment on, but is it much more likely than not to progress and become bigger patches or more in number patches, more numerous patches? Or does it sometimes just
stay as one isolated patch?
Just stay as one.
It's a really, really good question. And the answer is, for any individual, we don't know. So sometimes people will have a patch of vitiligo, and it will just be one isolated patch, and it might be on a part of their body which really doesn't bother them. It might just be on their chest. They've got one small circular patch they're not bothered about. That might be all they ever get in life, and that's the end of it. And they're happy with that. But in other people, they'll get the patch on their chest, and it will slowly spread or enlarge, and very rapidly enlarge, in which case they'll probably go to a doctor sooner rather than later. Other people might get that isolated patch on their chest, nothing then happens for 5 years, then they might get another patch on the opposite side of their chest 5 years later, and it might spread at that point. So the time course is very, very variable. What I would say is that if anybody is watching or listening who has vitiligo, suspects they have vitiligo, please, please, please go and see your GP or dermatologist sooner rather than later, because there are things that can be done, particularly if you can get to vitiligo within the first 6 to 12 months. So there are things like topical steroids, topical tacrolimus cream and ointment, that can be put on. There's phototherapy. As I said, there are newer biologic agents, so tablets, creams, immunosuppressive tablets that can be given, all of which can be given for vitiligo, but I think are not given because patients think, and sadly many doctors think, there are no treatments available for it. And whilst it's not life-threatening, but it's certainly life-impacting. So if you develop the beginnings of what you think might be vitiligo or patches of depigmentation on your skin, please see your doctor sooner rather than later, because there are things that can be done.
Okay, and I want to talk about treatment options now. So maybe just for ease, let's stick with vitiligo. Those treatments that you've mentioned, I don't know if you want to go into them a bit more, but what I'd want to know is, what the options are, and are there any risks of treatments, side effects, complications,
Sure.
that kind of thing?
Yeah. So what I would say is, for vitiligo, if it's asymptomatic, and what that means is it doesn't itch, it's not painful, which vitiligo doesn't normally itch people. It doesn't normally cause any pain. But there are treatments available. And normally, if I was seeing you as a dermatologist, I would start off with topical treatments or cream-based treatments. So one would be a topical steroid, right? So steroids work by dampening down your immune system. So what vitiligo is caused by is by your body's immune system being hyperactive, and it starts, for reasons we don't fully understand, it starts attacking your body's cells that produce melanin, the pigment-producing cells, and that's why you lose pigment there. So what we want to do is turn off that autoimmune process. So we would give a topical steroid cream, normally for a few months to begin with. Now, if you're giving steroid creams for a few months, there's not for a handful of months, I should say, in a restricted way under supervision, there aren't really any side effects to it. But if you were to use steroid creams for several months at a time without any break, without supervision, there is the risk of them thinning your skin. So it's not a long-term option for vitiligo, and that's why we sometimes use a different cream called tacrolimus or pimecrolimus, which is like a steroid cream, but not a steroid cream. So it doesn't thin your skin, but it does dampen down your immune system. But they do sting a little bit more than steroids do. They're slightly more expensive, which is probably why they're not used first line by many people. But the creams, if they're effective, they can work really well, but they tend to be more effective if the vitiligo is more confined, so on one or two discrete areas, and not rapidly spreading. I think if you're using the creams and it's rapidly spreading, then the next stage would be some form of either tablet treatment, so oral steroids can sometimes be used, but more commonly phototherapy. And what phototherapy is that you would go to a dermatology department normally, and it's like having certain wavelengths of light shone all over your body. And what that does is it reduces the immune system, in your skin at least, all over the body, which allows the pigment cells just to recover and for the pigment to appear back. And that's something that's very widely available, not just in the UK, but throughout the world. The waiting times obviously depends where in the world you are and the nature of the health system that you're in. But that is a very, very effective treatment as well. The newer agents that I mentioned, the biologic agents, so there are creams and there are tablets as well, but they are far more expensive, and they're newer. The side effects we don't fully understand yet, but the big barrier there is going to be the cost of them. So in some health systems, so such as the one we're in the UK, at the moment, the biologic agents aren't licensed for vitiligo. So if you were somebody that may benefit from them, you probably wouldn't be able to access it in our national health service in the UK as things stand at the moment. As time goes on, I hope and I imagine things will change, but as things stand, you can't. And then if you've gone beyond the first sort of 12 months, it is more difficult then to recover the pigment through those means, but there are surgical options as well. Again, they're more limited in the UK, but certain places in the world, so in Singapore, where I did part of my training, in Saudi Arabia, in the US, in I think Belgium, there are specialized centers where they do melanocyte grafting, where they can get pigment cells from elsewhere on your body and implant them onto areas of vitiligo and get great results with that as well. So that is an option there, but the best means of stopping the vitiligo rather than needing surgical approaches is actually to stop the vitiligo spreading to begin with, so get your treatment early. The other question I sometimes get is, are there any supplements that can help? Now, there aren't really any great evidence-based supplements for vitiligo, but there are some smaller studies suggesting a supplement called polypodium leukotomos can be helpful for vitiligo to help repigmentation alongside other treatments. And again, some other antioxidants like ginkgo biloba are sometimes thought to be helpful as well. But these are in addition to other treatments, not instead of them. But that's vitiligo broadly in a nutshell. With regard to hyperpigmentation, so that's increased pigmentation of the skin, again, it does depend on the underlying cause for your pigmentation, but there are a few broad principles that would apply to almost anybody with a hyperpigmentary condition. Step number one is that if there is an underlying cause for the pigmentation, you absolutely need to stop that. So if somebody was seeing me in clinic and they have active acne or eczema or psoriasis, which is causing post-inflammatory hyperpigmentation, the number one priority is to turn off that inflammatory process. So to treat their acne aggressively if needed. So instead of using tablets or creams, we might step it up to more intensive tablets, or even injections or phototherapy potentially for eczema or psoriasis. If they've got a drug which might be causing pigmentation, there are quite common drugs which do, like the tetracycline antibiotics, some antimalarials, some HIV medications can do that, some anti-epileptic tablets can cause pigmentation, some cardiac drugs can cause pigmentation. So if there are any of those, and if there's the option of switching them to something which is less likely to cause pigmentation, we would do that. The other thing I'd warn patients is that if they are having laser treatments or peels which are causing their pigmentation, absolutely just stop the laser treatments and peels, and don't try treating post-inflammatory hyperpigmentation caused by a laser or peel with a different type of laser or peel, because it often just gets worse. So the first step I would say is treat any underlying cause for the pigmentation. The second thing is that we know that the sun makes pigmentation worse. So for somebody with a pigmentary condition, the mainstay of treatment, and you can do this before you see a doctor or whilst you're waiting to see a doctor, is to use a broad spectrum sunblock. And by that, I mean something which protects against UVB, so ultraviolet B, ultraviolet A, as well as visible light as well. So when people think about sunblocks, we have to think about what we call the solar spectrum. So sunlight, which is the solar spectrum, it emits a whole range of different wavelengths of light. Now, some of them are shorter wavelength, like UVB, and that's the one we often think about. And that's the one that often causes burning of the skin. It's shorter wavelength, it doesn't penetrate deeply, but it causes immediate burning of the skin. So on your sunblock, when you're looking for protection against UVB, that's what your SPF refers to. So if it says SPF 30 or SPF 50, that's protecting against UVB, which is great. But what we know with pigmentation is it's, as well as UVB contributing, it's actually longer wavelengths of light like UVA, as well as visible light, that cause the pigmentation and make it worse and longer lasting. So if you have a pigmentary condition and you're picking a sunblock, you want one that protects against UVB, but also UVA as well. So in Europe, what we'd look for is either UVA with a circle around it or a 4 or 5 star rating for UVA. And as well as that, you want something which protects against visible light as well. So you want something that it's normally tinted, but contains either zinc, titanium, or iron oxide. And iron oxide is normally the best one that protects against pigmentation. So if you are picking a sunblock, ideally one that protects against UVB, so SPF 30 or 50 or above, UVA, as well as visible light as well. So a tinted one that can protect against that can contain ideally iron oxide to stop the pigmentation getting worse. Now, when you're using your sunblock, just remember that you ideally want to use 2 finger lengths worth of sunblock on the entirety of the head and neck every 2 hours if you're outdoors. That's how much you need to do to block all those wavelengths of light getting to your skin. That's not practical for most people, I will say, including myself. But if it's possible, I'd encourage people to put them on in the morning, so 8 o'clock in the morning before you go out, and potentially top it up at lunchtime. But if you are outdoors going on a walk, it's not to say you can't go outdoors or on a walk in the sun or play on the beach, but just make sure that you're topping up your sunblock every 2 hours if you're doing that. And another cheat as well is that when you are outdoors, if you've got pigmentation around your eyes, wear sunglasses as well, because they protect the skin around your eyes and also the back of your eyes as well. As well as your sunblock, you might want to use other sun avoidance measures as well. So whilst I'm not averse to people going out in the sun, if the sun's at its very peak between 11 in the morning and 2 or 3 in the afternoon, you might want to avoid it then or stay in the shade at that time. So try to get outdoors earlier in the morning or later in the afternoon. So it's just using sort of common sense there. So sorry.
Hats.
Yeah, and absolutely hats as well. Yeah, so using hats as well. So wide brimmed hats, and if you've got pigmentation on your arms as well, think about wearing longer sleeved clothing. So longer sleeve shirts and longer sleeve skirts or trousers as well. So as well as protecting yourself from the sun, as well as treating the underlying cause of the pigmentation, protecting yourself from the sun, there's increasing evidence now that actually toxins, so pollutants in the environment, can contribute towards pigmentation as well. So if you look at certain pigmentary conditions like solar lentigines, which are related to photoaging, so sunspots related to aging caused by the sun, and also melasma, they're far more common in cities, for example, in China and India, than they are in the countryside in China or India. And you can extrapolate that to, where we're sat now in the UK, and it's something that we see in nature as well. So our body's reaction to pollutants seems to be to produce more melanin. So we're sat in, near enough Manchester at the moment, but if you ever go to a city centre in, say, Manchester or London, you'll notice the pigeons are really dirty, dark grey, whereas in Cheshire, where I sometimes work as well, where we both sometimes work as well, I think, the pigeons aren't quite so dark grey. And rather than actually the pigeons absorbing loads of soot and smoke into their feathers, it's actually because they're producing more melanin as a means of protecting themselves from the sun and the pollutants. So something else I would tell people is that as well as your sunblock, you want to make sure you're cleansing your face, particularly if you're in a city environment, so cleansing it before you go to bed at night time as well, to get rid of any pollutants on the skin which might be making it worse. So following that, so you can do all those steps yourself without necessarily seeing a doctor at that point, but then it comes to depigmenting agents as well. So agents that you can apply on your skin to reduce your pigmentation. Now, some of those you can purchase yourself over the counter, and some of them your doctor can prescribe. And normally the ones your doctor can prescribe are a lot stronger than the ones you can buy over the counter. Now, there are a range of different depigmenting agents, but the most common one is one called hydroquinone. And in the UK or in Europe, it's often mixed with in a triple combination cream. So it's combined with hydroquinone with a topical steroid cream, as well as a topical retinoid cream. There's a brand called Pigmenorm, which is more common in Europe. In Asia, the brand leader, I think, is Triluma, and there are variants of that around the world as well. And that's something that it works very well, but you tend to have to use it in an escalating fashion. So you use it twice a week for a couple of weeks, 3 times a week for a couple of weeks, and then every night after that, because when you first put it on your skin, it can be a bit irritant. It can sometimes induce acne type spots, and it can sting a little bit. So I tell people to build it up slowly over time. And that's normally effective. If you were using hydroquinone, I'd always encourage you to use it for a finite period of time. So I typically say 3 months, and ideally under supervision by a dermatologist as well, because there is a very rare but irritating complication called ochronosis. So if you're using high concentrations of hydroquinone and you're not supervised using it for long periods of time, you can develop ochronosis. It's rare, but it's very, very difficult to treat. So, but if you use hydroquinone in a safe, supervised fashion, it's highly, highly unlikely to happen. But there are other alternatives to hydroquinone as well. So other ones that you can either be prescribed or purchase yourself are other depigmenting agents like azelaic acid, thiamidol, melasil, and a whole host of other agents, kojic acid, resveratrol, resorcinol, which are related to hydroquinone as well as a load of antioxidants as well. So using a depigmenting agent would be something else that I would encourage people to do as well. Ideally, one prescribed by your GP or doctor or dermatologist, so it can be given in a regulated, structured manner and at the highest strength to get you the best results as quickly as possible. Specifically for people that have melasma, there's great evidence now that there's a treatment called tranexamic acid. Now that's one that I'm sure you'll be familiar with, Dr. Faisal. Yeah, so it's often given to ladies who have heavy periods. It stops bleeding, and sometimes trauma surgeons give it as well to stop bleeding in trauma cases. And the main way in which it works is it causes your blood cells to clot. So it stops you losing blood, and it causes clotting. But it also actually works on the enzyme which produces pigmentation as well. And when given for melasma at a very low dose, it actually in about 90% of cases it completely clears the melasma. Right, so it's really, really good. But it's only available from a doctor. And it's off license. So it's licensed to indicate the licensed reason why we can use it is for bleeding, but it can be given off license or off label by a doctor or typically a dermatologist for melasma as well. And that's helpful to know, because if you've got melasma that's debilitating, or there's an occasion like a wedding or a wedding, birthday, anniversary, job interview that you want your skin to be as clear as possible for, it's an option to have tranexamic acid for a finite period of time. So that's something else that's helpful to have. The other thing, the question I often get is, can lasers or peels be helpful? Whilst I do laser treatments myself, I tend to say to people, the topical treatments for pigmentation are the foundation. And if you have melasma, using tranexamic acid, they're the foundation. And I will say that I've seen far more people being harmed by laser treatments or peel treatments that they may have tried off aestheticians on the high street than I have seen helped by it. And that might be sort of case selection. Obviously, the ones where it's not worked may have come to me as a dermatologist to be seen. But I will say that the topical treatments are the foundation first. But there are certain conditions where laser treatments are the best. So if you have drug-induced pigmentation, you've stopped the drug, you've still left with some pigmentation, lasers can be helpful. And certain rarer conditions like nevus of Ota, where you can get some bluish discoloration around the eyes, nevus of Hori, where you can get some pigmentation on the cheeks, there lasers can be helpful. But again, if you're looking for laser treatments, make sure you're seeing ideally a doctor who's very trained in treating people with pigmentary conditions. And if you've got skin of color, for a doctor that treats pigmentary conditions in skin of color with lasers on a regular basis, so they know what's safe and what results you're likely to achieve. Another thing I would say to anybody listening is that bear in mind that there are great camouflage services around as well. So if you have a pigmentary condition, you've tried many of the treatments, or whilst you're trying the treatments, the pigment hasn't quite gone back to normal, there are a range of makeups you can use, and there are services that you can access to teach you how to camouflage any pigmentation as well. So in the UK, there's a charity called Changing Faces that people can refer themselves to. They offer an absolutely fantastic service, free of charge. You can log onto their website and they'll direct you to a clinic that's close to you. The slight problem is that sometimes they have quite a long waiting list, but the patients that do make it there and they wait out the waiting list, they find it incredibly helpful. So they're an incredibly helpful resource, and there are similar charities in other clinics in other countries as well. And finally, I'd say just to bear in mind the psychological or psychosocial impact of the pigmentary condition as well. So what I will often ask my patients is, would they like me to refer them to a psychologist, particularly one that specializes in the link between skin diseases and the mind? Because we know that by having a severe skin disease, including a pigmentary condition, it can impact on people's mental health, their anxiety, and how they perceive themselves, and they get into a vicious cycle. So by helping to break that cycle early on, they will feel better about themselves and maybe better able to engage in the activities they want to sooner rather than later. So that would be something else that I'd encourage people to do.
Excellent. That's good. Holistic care, isn't it?
Absolutely.
Okay. Wow, that was an extremely thorough explanation, and thank you very much. And I will put links to the charity in the show notes for anyone who's interested, because it sounds like really good work and very valuable information. So my last question for you, Faisal, is that you, throughout your career, have seen many, many patients, and it's your passion for treating this shines through, actually. So thank you for all that you do. You've seen many patients with disorders of pigmentation in your career. Given the opportunity, what would you say to anyone who was perhaps wondering about it, perhaps struggling with a disorder of pigmentation? What would you say?
I mean, firstly, I'd say you're not alone. So around 50% of people around the world are bothered by some sort of pigmentary condition. So you're not alone. Secondly, is that there are loads of treatments out there. So please don't sit at home worrying about it yourself, but see your doctor, see your dermatologist sooner rather than later, because there are lots of treatments out there, some of which you can buy yourself over the counter and some of which might be available on prescription. The final thing just to say is that just because you have a pigmentary condition or any health condition, you've got the right to feel confident in yourself and in your own skin. So please just go out and seek help if you need to.
Perfect. Thank you. Well, the only thing that remains, Faisal, is for me to, again, say thank you so much for joining me today. It's been a complete education. I mean, an education just on sunblock alone was worth it. Phenomenal.
Thank you very much.
Complete education.
Yeah. No, I was just going to say
thank you very much for joining me. And thank you, most of all, thank you for all the good work that you do every day to help numerous numbers of patients with various skin conditions, including pigmentation, about which, as I've said, you're obviously very passionate. Thank you so much.
No, thank you.